policy advocate from Western Center on Law and Poverty. So to you, Ms. Cooper.
Thank you so much. So one, I want to start with where we are currently providing incentive payments to our managed care plans today. So currently, the department rolled out an incentive program through Prop 56, the Behavioral Health Integration Incentive Program that is currently funded under the same type of funding mechanism of the 5% within a capitation rate that we are proposing the calAIM incentive payments to be provided. Essentially, it provides incentive payments to managed care plans for achieving specified milestones and measures, and then we pay based on the outcome of completing those incentives. And so that is just an example where we provide that today. Under the calAIM proposal, what we're really looking to do is establish plan incentives that would really drive to many of the things that we've talked about today. The department thinks it is really critical, especially for areas that currently don't have these services in lieu of and enhanced care management, for them to be statewide. But we do know that there's going to have to be some investments to get us there because that is one of the founding principles of being provided. We also want to make sure that there is a sustainable funding source for those services, including federal funds to draw down and not subject to local allocations or dollars being invested into them. And so really what we're wanting to do is incentivize that build, both for enhanced care management models across the state of California, as well as the in lieu of services infrastructure. So these incentive dollars are really focused on how do we get the capacity, the infrastructure, the training out to individuals. As mentioned earlier, one of the core principles of enhanced care management is that that entity is responsible for all of the care management services. That includes the physical health, the behavioral health, as well as the social aspects of that service. And there are a lot of technical assistance which we would need to provide. These incentive dollars will help with some of that training, best practices, et cetera. It will also focus on performance improvements and quality outcomes, where we can see drivers and incentivize plans to increase the use of in lieu of services, for example, across the state of California. We know that that's really important to do to eventually get to a place where we could potentially offer some of these as Medi-Cal benefits versus just the in lieu of services path. So critical component of these dollars. I would also just emphasize that they can pay for various IT workforce training and other pieces. And I'll go through a list later in regards to some of those pieces. We do plan on having and conducting robust stakeholder feedback. I'm hoping that in early summer, we'll have something for people to review and provide feedback on to the department so we can get that information out early to managed care plans and providers so they understand the types of incentives that we will be offering through the calAIM proposal. We do propose that milestones could be met and dollars can flow as soon as January 1 of 2022. And being able to trigger those incentive payments are really important, especially if you're trying to build capacity, for example, in enhanced care management, that is a target population aimed for maybe a January 1 of 23 timeline. So we do know that we want to make sure that infrastructure and opportunity is available for our plans and our providers who are wanting to execute that. Some examples of things that could be included to trigger the payments include workforce training, technical assistance, regular data sharing between community-based organizations, and making sure that those barriers that they may have are being removed so that they can be providers in this program. Gap needs analysis, so better understanding if there is any providers out there who provide these services, doing that gap analysis on the ground to understand how we can close those gaps with additional incentive or infrastructure dollars, as well as capacity building, successfully implementing transition plans, like including and ensuring that county behavioral health providers are at the table to provide some of these critical services when they're willing to accept the requirements of things like enhanced care management and what comes with that, of course. The dissemination of best practices, as well as meeting various performance measures and across access, quality, outcomes, as well as equity, something that we'll be very focused on in some of our performance incentive dollars that will be coming out. So I think those are just some examples of things that we are considering and look forward to engaging people in the future in regards to those incentives. I think broadly, the incentives will be paid on the managed care plans based on the milestones, as I mentioned earlier, and just flagging for people under federal regulations, we are required that we cannot go, exceed the 5% of their capitation payment. So we will be closely monitoring that through this process as well. And then on the last question requested for the department to ensure we address around shared savings, federal regulations does require the department to take into account both the utilization and actual cost of in lieu of services when developing capitation rates. And the managed care plans already have an inherent financial incentive to provide authorized in lieu of services versus the more costly state plan services, regardless of that rate methodology that's outlined. That's one of the inherent reasons why we really hope and encourage all of our managed care plans to implement the in lieu of services, because by nature of them being approved, they are less costly than state plan services that are otherwise potentially being utilized by that beneficiary. However, in order to encourage managed care plans to fully engage in the goal of developing both long-term services and support, so around a lot of those home and community-based services mentioned earlier, as well as the clinically linked housing continuum infrastructure, the department did propose to implement a shared savings risk model that would begin in calendar year 2023. And the shared saves risk modeling is broader than just in lieu of services. We're really trying to incentivize the investment in those types of things, care coordination, in lieu of services, really looking at how you can reduce the overall cost, but really improving the beneficiary's health outcomes and then measuring it. So that's where we will focus that. Further details are still being developed in regards to that shared savings and risk model, but look forward to engaging with individuals as those details come available. And that concludes my comments at this time.
Thank you very much. Move on to Ben Johnson.
Good afternoon, Mr. Chair, and both chairs. Ben Johnson with the Legislative Analyst's Office. So the administration proposes ultimately over 2.5 years, $750 million general fund, $1.5 billion total funds for the incentive payments for managed care plans to build the infrastructure that Director Cooper just described, largely around enhanced care management and in lieu services. We recognize that these payments may be necessary for one, sustaining the existing service levels through programs that calAIM would build upon or replace. So sustain the service levels that are provided through health homes and whole person care that would both sunset next year as calAIM implements. And in addition, we understand that this is an important incentive funding as well for managed care plans to really build out the full set of ILOS services that the state potentially hopes for them to provide under calAIM. However, we do have concerns around the lack of detail with this proposal. To date, the administration has not provided a comprehensive list of what plan activities would trigger a payment, detail on how much funding would be provided for each activity, or how the program rules would ensure, where appropriate, that the case management and supportive services infrastructure created under whole person care and health homes are sustained. And as Director Cooper noted, they do plan to release sort of a broad detail on this proposal, but it sounds like the intention is for that not to come out until the early summer, and this may not give the legislature adequate time to scrutinize the details of the proposal prior to deciding on whether or not to approve the funding. In addition, we do question whether the multi-year funding plan related to incentive payments is realistic. The governor's, as I said previously, the governor's funding plan would have the funding sunset after 2.5 years. But we find this questionable for the following reasons. First, it's that Medi-Cal managed care plans are funded based on their prior cost experience. And so if the incentive funding is ultimately used on services, including, for example, ILOS services, whose costs are reimbursable, then Medi-Cal managed care plan funding likely would increase naturally to cover the higher reported costs. this is not accounted for in the multi-year funding plan under calAIM. Alternatively, even if the funding does not end up covering such reimbursable costs, there could be pressure to reauthorize this funding to sustain the services that the incentive payments would support. While the administration assumes that savings from improved cost effectiveness of the services provided to beneficiaries under calAIM could sustain the infrastructure for providing ECM or enhanced care management in lieu of services, we question whether this assumption is realistic, particularly in the short term, as such savings could take many years to materialize. So in sum, we do have questions related to the lack of detail on this proposal and about the multi-year funding plan related there too. We also have outstanding questions that we raised in a previous analysis related to the lack of detail on the shared risk share savings components. Really just would be looking for more detail before we could advise the legislature whether or not to approve that component of the calAIM proposal. Thank you.
Thank you very much. Dr. Hansberger.
Good afternoon. IHP appreciates the department's acknowledgement that an incentive program is needed to incentivize foundational investments needed upfront to support the hiring and the building out of needed clinical and technical supports. As illustrated by my earlier comments, a lot of time and resources will be required to develop and expand this infrastructure. Given the incentive payment program is time limited, and considering the extensive work needed to build a foundation for a successful launch and sustainment for ILOS proposal, IHP supports an incentive program that will allow us the flexibility to build the capacity of provider networks, develop needed infrastructure, and invest in data sharing, making sure that we are setting up the program for the greatest possibility of success. We believe the incentive program should both maintain and expand existing infrastructure, developing infrastructure where it does not currently exist. Specifically, first, incentive payment funding should be available for the initial investment to include planning, development, and implementing of ILOS services. In many cases, this funding would be for startup costs needed for services that could be provided. For example, in the Inland Empire, we do not have one sobering center. So that would be a very heavy lift for us to be able to put that infrastructure into our geographic area. Secondly, incentive funding should also be available to maintain and expand ILOS services, including those provided by whole person care pilots and those provided by IHP today. In many cases, these services are offered on a limited basis and require funding in order to expand to additional geographies and expand member eligibility. Lastly, incentive payments in the early years we would encourage to be focused on process activities while the capacity is being built, with outcome-based performance incentives after, so once there is capacity and infrastructure in place. And for example, this could be done by looking at the number of recuperative care admissions or number of meals served, housing placements that are for the foundational support of funding, later to be then changed over to reduction of costs and health outcomes in these members, because we know that these services take time to be able to show a return on investment. As briefly mentioned in my earlier comments, in order to meet the July 2021 submission deadline for our ECM LOS model of care plan documents, it is critical that the plan understands what the incentive program structure will be. We need this for several reasons, including to give the plan the opportunity to properly negotiate contracts with providers and to accurately provide the details needed to be solidly ready for a January 1st, 2022 go live. Thank you for your time, and I welcome any questions on the panel.
Great, thank you. Moving on now to Linda Way from Western Center on Law and Poverty.
Good afternoon again. Linda Way with Western Center on Law and Poverty. Before the department asks plans to take on new responsibilities, the state must ensure plans are held accountable for minimum performance standards, network adequacy, timely access, language access, and physical accessibility. The timing of calAIM and the reprocurement schedule align well to ensure plans are able to meet these basic standards as a condition of contract renewal. Incentives must center health equity and focus on eliminating health disparities as well as improving quality. It is unclear how this fits into the state's current managed care plan quality strategy, so we request the department align its quality and health equity efforts across its different initiatives. As previously mentioned, we have concerns that plans will resort to familiar practices and contract with medical providers and clinics that they have an existing relationship with. So recommend incentives be focused on developing partnerships, specifically with social service organizations that have successfully offered enhanced care management and in lieu of service type services to target populations. This can include technical assistance for social service organizations to build their own data system, to contract with plans, and receive referral information for more integrated care. The department should expand its proposed financial incentive programs from enhanced care management in lieu of services and tie it to successful implementation of the new population health management initiative and quality performance thresholds more generally, which will benefit the entire Medi-Cal population. Incentive payments should be based on improved health outcomes and how many beneficiaries are actually screened for and receiving needed services, rather than driven by reduced costs and utilization. Incentive payments should only be pursued if able to drive behavior change and not be provided for actions plans should already be doing. To ensure that the department accomplishes this goal, it should articulate specific measurable targets that calAIM and plans will be expected to achieve and report on these progress at least annually. Thank you.
Thank you very much. I'm going to questions from the committee. Dr. Rambula.
Thank you, Dr. Wood. I'm going to start, my questions are for you, Ms. Cooper. I'm going to start with where Ben Johnson ended, which is a need for more detail. I was intrigued by the milestones referenced in the agenda today, and you provided some details regarding those milestones in terms of workforce training, gap analysis, and capacity building, but was hoping you could expand about what specifically that could mean for counties and Californians.
Let me give a few more examples,
Yes,
if that's helpful.
Yep.
Okay, great. Sorry. So I think there's a number of things. For example, as was mentioned by one of the previous speakers, some of it could go to direct capacity building. For an example, recuperative care beds. By increasing access to 50 new recuperative care beds, there could be an incentive payment. So the idea behind incentives, the way we're building them, is that you actually have to have implemented and achieved it to get the dollars, and really driving around building that capacity for enhanced care management and in lieu of services from an infrastructure point of view. So that's one example. Another one would be promoting best practices and expertise for enhanced care management or in lieu of services providers. So managed care plans that implement robust community engagement efforts where they are providing a loop, a round of technical assistance, care kind of coordination pieces, and best practices for enhanced care management, as well as providing training for those beneficiaries, potentially would be one for payment. Encouraging engagement with providers. So actually, as just mentioned by Ms. Way, looking at how we can incentivize certain providers to be at the table participating, including public hospital systems, county behavioral health providers, community-based organizations who have a lot of experience in this space, and making sure that they are connecting with those expertise providers to do these services. I think another one we are looking at is encouraging data reporting and the collection of that, as well as some of the infrastructure needs that would need to be put in place for that. Workforce development, as mentioned earlier, as well as a variety of kind of outcome-based measures. And by that, I mean we are looking at equity measures that we could consider, as well as just access measures. So increases to enhanced care management services over time, as well as in lieu of services. We're also looking at specific things where we know certain individuals, for example, individuals of color, Black and African American beneficiaries are higher numbers of homeless individuals, and targeting certain models of care to reduce some of those equity gaps would be a critical piece. As we're building out the enhanced care management for reentry from the jail population, there's going to be infrastructure and capacity challenges there, finding the right workforce and training that workforce to do those things well in partnership with our county colleagues, incentive dollars there. So I think we are really focused on access, infrastructure, capacity, as well as those outcomes. It's got to be a balance of some of the metrics that we can look at, but as well as getting dollars out the door to incentivize managed care plans to close gaps where we don't have in lieu of services today, building that, and where we only have capacity for a certain number of people, growing that capacity to meet the need of that given county.
Thank you for that. The one I didn't hear that I've always been interested in is regarding workforce training and how we make sure that it reflects the diversity of our state. And as we're talking about closing the gap, I was hoping you could talk about whether these incentive payments could help us to address that issue.
Sure. So workforce training can definitely be a part of these incentive dollars, especially because a lot of the work that we're talking about for both enhanced care management and in lieu of services is both a combination of clinical but really non-clinical services where we really could increase the workforce in this space, really engage with people to provide these services, whether that's community health workers, as was mentioned previously by one of our speakers, but really growing that. So yes, it's definitely something that we can make sure is included. It's something that's been on our list. And figuring out how we get that workforce trained and ready to provide this work. We know it's one of the biggest opportunities or areas we need to focus on with these incentive dollars because of the non-clinical lift that's needed, and just given the workforce pressures across the entire state today in healthcare.
I thought it was appropriate when Linda Way brought up network adequacy and incentive payments for us to make sure that the managed care plans are meeting those requirements. And hopefully, if those incentive payments are needed for us to work on workforce training, I think my concern would be that they're limited time in nature and the needs for our state are great. My colleague and co-chair was on a task force that looked at needs for workforce and identified $3 billion over the next 10 years. And really do hope that we've learned a lesson from this pandemic, that you can't make doctors and nurses overnight, that we have shortages in regions of our state, and that these investments are not just important, they're absolutely necessary for us. Thank you very much.
Very well. Well, thank you very much. We'll go ahead and move on to, with that, we'll move on to our next panel.
We will now move on to managed care, Medi-Cal managed care plans to have a population health management program. We will have 5 presenters. We will begin with Ms. Cooper.
All right. So in the calAIM proposal, the department is recommending to require all Medi-Cal